you skills. And just for those of you that know, you know, but those of you who don't, I have a whole class that I teach this in USFAQ, and I teach, I'm going to go through the skills, you know, today in like 30 or 40 minutes that I actually train and teach over 15, 16 weeks. So, and it's a course that I designed, you know, with the help of Dr. Gerber, you see on the forum. He was one of my professors in undergraduate. And this is a course that I've developed over time that was, you know, I deemed necessary. What I did in the US was I was the clinical director of a forensic ACT team, so criminally insane population. And I found that a lot of these already developed clinicians didn't have a lot of some really basics, didn't, you know, under this course of how to break. And I also find that if you can get good at skills, and then over time you can develop into the artistic part of being a therapist, which is the important distinction. And first you have to, you know, be, you know, skillfully proficient, and then once you understand the skills well enough, then you can become artistic within that. An example is like, think of like soccer players that, you know, they look really artistic after they're really good and been doing it for a long time, but, you know, we don't see the drills that they have done their whole life to become proficient at like dribbling the ball and kicking and all that stuff. So that, okay. And I don't have any problem if you have questions along the way. So I'm kind of the professor that I like some engagement. So if you have a question, you know, just throw it in chat. If you're scared to like just blurt it out, but you can just blurt it out, I'm totally fine. Or I don't know what Judy prefers. She's the boss. I'm just the presenter. So whatever she wants. So Judy, if you have a different idea, you know, tell me that.
Yeah, Richard. Yeah, the people can raise their hands and you can answer their questions, or if you prefer, they can answer at the end. It doesn't matter.
Yeah, I'm good with questions along the way. I mean, if you can hold your question, that's fine. But if you can't, like I couldn't hold a question. If I had a question, I'd be like, ah. So I guess put your hand up, and then Judy will let me know, because I'm not monitoring that aspect of the room.
Okay.
Right, Judy, you're going to watch all that. And I'm not looking at chat either, so
Okay.
it's too distracting. And that's like this an example. Well, I guess I can open chat and just keep an eye on it. But yeah, I think Judy, you got that right.
Yes, don't worry.
Perfect. Okay, so we're going to start with, so the model that I've developed, we call it the SITE skills training model, and SITE stands for sequential, initiating, tracking, enhancing, right? And being a therapist is a really complicated, you know, endeavor. And so there's lots of things that need to happen, right? And so what I've tried to do is break these out. And some of this came from Dr. Gerber, my old undergraduate professor. And he helped me with, you know, developing, we have this whole model that we've developed over time. He's done more of the development. I've just done lots of utilizing and training from the model, but this is the beginning of the model. So we're going to learn SITE skills. So it's an easy way of remembering. Sequential, initiating, so it means in order, initiating, how to track, and then there's some enhancing we probably won't get to today just because it's the time. And again, these are, I'm doing this quick and dirty, but these are the course that I train, like it's not clicking for me. Here we go, train over a whole semester. And so starting looking at communication, this is the way, especially to look at communication in relation to clinical practice, right? So you start with a really shallow conversation, you know, hi, how are you? You know, you guys are, if anybody asks you how you are, you all say good, whether or not you're good or not, like that's an issue for me, and that should be an issue for you in your private practice. If you're a clinician, you know, hi, how you doing? I'm good. Okay, fine. See you next week, right? We have to train our patients to be like explaining to us actually how they're doing, but there's techniques how we can do that, and I'll talk about that. But if you look at communication in a funnel, we start really shallow, and then the deeper you get, you start getting into messages, themes, what the patient is conveying, you know, verbally and non-verbally, you know, and what's really happening. And then you get down further, down deep into the funnel. That's when you get into really technical things, you know, precise things. That's when the communication is really pointed and precise, but you can't be pointed and precise without starting, you know, shallow, right? So you have to start and then go down, right? Same thing with any kind of skill. You start and then move down the communication funnel. I'll keep this funnel on the screen so we can refer back to it, you know, as we talk. And here's just another. And this, if you're a non-visual person, like these two screens are probably freaking you out and you're not learning anything. If you're visual, you're like putting this stuff together and you're probably breathing. And then when I go to other screens, you'll be like, ah, right? So hopefully you know that about yourself, you know, if you're a visual or non-visual learner. If you don't figure that out, that's really important for your learning style, and it's really important for when you treat people, right? Just imagine if there's a mismatch. You're very visual in the way you process information and your patient is not, they might not be able to track with you very well. But here's just another, you know, more detailed description at the top. You know, it's really shallow, imprecise. Hey, what's up? How you doing? How things? I'm great, right? But then when you get down lower, you know, you start talking about, well, why are you so great? Well, I'm so great because I had a great week. Or the opposite is usually true. You know, you know, the mantra that patients usually say is, nobody loves me, everybody hates me, I'm going to go eat worms. Right. Our job as clinicians is to figure out what the worms are and maybe get them to eat gummy worms as opposed to nasty earthworms. Right. But that's the mantra that most patients say. But when you get down into, and most of you say it, we say it as human beings, as you get down lower into the communication funnel, you start getting more precise, start attending to things differently. Right. And then when you get deep, you know, just think about the communication becomes pointed and specific. It's when you really started getting into the important details of tracking what the patient is saying, how they're saying it, why they're saying it, and we'll talk about like the ways that you do that. But this is like the overarching theme about how communication works specifically in the therapy world, but this works in relationships and everywhere else too. Right? If you think about it, it makes sense. You start with, hi, how you doing? Right? Even if you have a problem, right? You start with, I'm great, everything's great, and then you get into the details with your friend or whoever you're talking to. Right? And so here's the basics of the model. And we're going to cover this today for sure. We'll get into, and then I want to get into the enhancing, but it's probably gonna, we'll run out of time. We won't get into this today, but I'll briefly show you. This is actually the, you know, one of the models that I've developed to how do you characterize and organize patients and issues, and how to break issues into, I have a triangle model that I go through, and how to break, you know, the affect and the behavior and the cognitions into silos, basically, so you can make a very complicated human being understandable, because we're really complex. Human beings are super complex. If you don't believe that, just think back to when you were an adolescent and you were slamming your door at your mom or your dad and you don't even know why, right? Look back at those crazy fights you had, and it really mattered to you back then, but if you look at it now, you're like, well, that was really not so important. We're very complex. So we're going to dive in. Here we go with the initiating skills. So we're going to start, this little box on the left is where we start. And I remember, for me, I remember before I sat with my first fake patient, because we did this whole thing in undergraduate where we actually practiced these skills in like a fishbowl. So the fishbowl was in, you had the inside office, and then outside was an auditorium, and there was all glass around it. And so there was like 30 of us in the class, and other classes would come and observe. And so like me and Judy would go inside the fishbowl, and I would be the therapist and she would be the patient, but we're both students. And I would practice some skills, and there was a phone right behind me, and the phone would ring, and it'd be Dr. Gerber, and you pick up the phone, and Dr. Gerber would say, Richard, what are you thinking right now? And you tell him what you were thinking, and he'd say, you're an idiot. You're thinking the wrong thing. But I remember thinking right before I went into the first thing, like, what do you say? Like, how do you even start a conversation? Like, what do I do with it? Like, what's up? Like that, you can't do that. So this is, you know, how do you even begin the conversation is an important concept. And the first thing that you do, it's called what's called an indirect lead, right? You ask somebody in a question in a way that they can't answer it with a yes or no. I mean, they can. If they're being an asshole, they can absolutely always say, I don't want to answer it, or yes or no. But generally, if you ask somebody an open-ended question, it invites some type of disclosure, right? And some examples of that is, you know, talk to me about why you're here. You know, give me some examples about things that are going well in your life. You know, share with me about how I might be able to be helpful with you, as opposed to tell me why you're here. I don't want to. No. You know, or sometimes you say, well, how did you get here? You know, what brings you here? A car, right? So you have to get good at thinking like, what's a good indirect lead? What's a way of inviting some disclosure in a way that doesn't, you know, cause somebody to be easily answered with a yes or no, right? Most of us, if we ask, you know, talk to me about what brings you here today, right? You're going to talk about whatever the thing is, right? As opposed to just saying, hey, what's up? Or, hey, what's your problem? Or how can I help you? Those are all questions that can pretty easily be answered with, you can't help me, but, you know, give me some background on you. Talk to me about the events that occurred before you got here today. You know, share with me what's happening in your life. Share with me how I might be able to help you. So just, it's part of, when I do this in class, we practice, practice, practice. I go around the room and make sure all of you get good at thinking, like that. So, but you need to do this on your own, like practice how to invite disclosure. You know, tell me why you're here. No. Tell me what brings you here today. No. Tell me what your problem is. No. But if you say, talk to me about some of your issues, right? That invites like a level of communication, and it's important. It's important to stop with that. And then remembering, so we're at the top of the communication fellow, right? It's a really shallow way of opening. Share with me what brings you here today, right? That's not a really precise, deep, meaningful, getting at the reflection of feelings or anything. It's just a way of opening the discussion. But the way that you open the discussion matters, right? If you open it in a way that's warm and inviting and causes some kind of back and forth, that's better than just, why are you here, right? And a lot of people do that. Why are you here? And when here's how I start a session, but I'm a different kind of clinician. I start a session like this because I want the patient to say something. I want them to begin, right? I try to consider myself as like a non-directive systems type therapist. So where they start matters to me, but not always, right? Especially if you're working with adolescent, you can imagine just sitting there, they'll stare you down most of the time. Grab their phone and just start looking. They're comfortable with you. They don't want to talk to you anyway, right? So you have to say some things like, share with me, what brings you here today. Share with me some issues that you're having with your family or something like that. Make sense? All right. And then, so that's initiating, right? That's like how you start the conversation. Talk to me about what brings you here today. And then they say a bunch of words. Well, I'm here because nobody loves me, everybody hates me, I'm going to go eat worms, right? The next thing you have to do is you need to make sure that you're understanding the patient and the patient is being understood by you. So a paraphrase is the next level, right? And one of the ways that you have to think about this is you have to be able to understand what the patient is saying, right? So at some point, pretty quickly as they're talking, you have to shut them up because you have to give back some information to them. Because many times you find in the therapeutic sense, especially newer clinicians, they don't know what to do and they get overrun by the patient. The patient just comes in and starts saying a bunch of words, right? And they've said word for 15 minutes, and then you have to be like, what do I do? So, but if you know that you have skills to hit, that the paraphrase is after the indirect lead, they're going to say some stuff and you're going to say, okay, so what I hear you saying is that nobody loves you, everybody hates you, and you're going to go eat worms, right? And the patient will say, like what Judy was doing right now, the patient will go, yeah, that's what I said, right? It's really important. And it's really important that you understand this is how we move down the funnel, right? You start with this indirect lead, talk to me about why you're here. And then they say, well, I'm here because I'm having a really bad day and my mom doesn't like me and my girlfriend doesn't like me anymore and I'm failing in some classes. And then they'll keep going, but you have to say, hold on. So it sounds like you're here because you're having a really bad day and you're failing in some classes and you're struggling with your relationship with your mom, right? And the patient's going to say, yeah, right. And this really simple skill too, patients will say things like, you really understand me. And if you're being honest with yourself, like as a clinician, like you could go back and say, well, not really. I just did a skill on you, right? I just paraphrased on you, right? I just threw back what you gave me, right? And a paraphrase is really a mirroring, phrase. And some of you are probably thinking, well, patients wouldn't like that and they would be offended by that. It's not really that way, right? There's some understanding that happens. And to see this in action, like it's easier for women because you're socialized around talking and communicating. So you naturally tend to do this easier. But where you can see it in action is go watch your mom interact with her best friends. You'll see this thing happening. Your mom's best friend will say, nobody loves me, everybody hates me. You're going to go, oh, so nobody loves you, everybody hates you, and you're going to go eat worms. And let's talk about that, right? So there's this natural paraphrase thing that happens. But knowing in the clinical world, it's a skill, right? So you start with an indirect lead and then you paraphrase, right? And when you're new at this, you might say something like, so what you're saying is that, you're having a bad day and you're having trouble with your boyfriend and you're having trouble with some grades, right? And the patient's going to say, yes, right? And it's not about being perfect, right? It's not about, getting everything perfect, but you don't add stuff. You don't change it. You don't say, so you're having a really, really bad day and your boyfriend's really mean to you and you think you're going to fail school. Like, because if you do that wrong, the patient's going to say, no, it's not what I said. I said, I'm struggling with my relationship. I'm struggling with grades and my mom's making me mad, right? So if you twist it too much, right, there's going to be a reaction from a patient. Or if you're inaccurate, right, the patient's going to correct you. The patient says, nobody loves me, everybody hates me, I'm going to go eat worms. And you say, or no, as the patient will say, my mom doesn't love me, my boyfriend's mad at me, and I'm going to go eat worms. And you say, nobody loves you, everybody hates you. No, that's not what I said. I said, my mom is mean to me, and my boyfriend is mean to me, right? So they'll naturally correct you. And just imagine in your normal day-to-day activities, you'll see this, right? Some of your friends will misparaphrase something that you do, and you'll say, that's not what I said. I said this. And it's the same thing in therapy. And you need to see some errors in that, right? Because part of this is when you learn to be a therapist is you have this agenda, you have your worldview, you have some ideas about the way you want things to go, and you're going to misquote people. You're going to paraphrase inaccurately, right? And then when you have good supervision, you'll figure out what your tendencies are, and you'll get better at that. Your supervisor will say, hey, stop with this because you're projecting too much of this. So you want to hear a patient, all the time. I did some paraphrase the other day, and the patient's like, that's not what I said, doctor. I said this, this, and this, and okay. So I was able to say I was back to this other thing that we were talking about. So I missed some of the information. And patient won't be mad at you and quit and leave therapy, right? That's a normal part of communication. But if you understand that it's a skill, right, then you also understand, so, okay, I hit the skill and I didn't do it very well. So I need to listen better because I'm not hearing what the patient is saying, right? Or, if you have a patient who is overly pathological or lots of pathology, difficult patient, right? And they might, every time you paraphrase it, like, that's not what I said. But that's diagnostic in and of itself, because now you have a patient the word is recalcitrant. They're difficult. They're going to constantly be challenging you, and they probably challenge a bunch of people in their life, right? And they probably will say, nobody understands me. I feel completely misunderstood. And you're thinking, well, I just paraphrased perfectly, and you just said no. So maybe this is your issue, but that's part of why the skills are relevant, because when you get good at skills, you're hitting them well enough, right? The way the patient responds is diagnostic. Clear? And the next skill is a blank face. So you just become blank and you clear yourself, you breathe, and then you get ready for the next skill. This is my favorite, second favorite skill of all time.
Richard, excuse me, we have a question.
Sweet. Let's hear it.
Okay, thank you very much. We have a question by Evelyn Guzman. She asks us, what skill you can use when a patient is expressing resistance or has difficulty expressing himself?
Hang on to that question because we'll cover that when we get to reflection of feeling. Yeah, good question. But you're way, way ahead. You're too far ahead. So yeah, breathe. Go back to this screen. And now go back. We'll get back to work. Good question. I will cover it. So the next skill is my second favorite. My favorite is this skill. Silence is my favorite, but we'll cover that specifically. But traffic signs are awesome skills. And these are a skill that you can start practicing today, right? You can start practicing very easy. So a traffic sign is any word that requires clarification. And it's basically any of the big words or the small words. Love, hate, anger. I'm really pissed off at that person, right? What does pissed off mean? Right? Because my kind of pissed off is probably different than your kind of pissed off. We probably, think about our family systems. We come from different systems. And so the way you deal with anger, understand anger is different than mine. And if I'm the clinician, my job is to get as close to your position as I can, right? So any of these words like, kind of, sort of, I should, he, she, weird. That was a really weird experience. Or I really struggled with that. Or pretty much, I'm pretty much there. Or I don't really know how I feel. Or I'm sometimes mad, right? And think of that, I'm sometimes mad. Those are two traffic signs, sometimes or mad, right? They're both traffic signs. So any word that requires clarification, and there's a technique, I'll show you the technique next, but any word that requires clarification, as the clinician, you need to be dialed into that and understand that you don't know what the hell the patient is really saying. Like if I say, I really love doing this, right? You have some ideas of what that means, but you don't know what it means to me. You have to figure out, what do I mean by I really love doing this, right? Do I love like the teaching? Do I love the questions? Do I, what is it? What is it? So you have to go back and clarify that. And I always think of this, like if we sat in this room, like this is a room full of however many people we are, and I said, look, all we have to do is decide on one definition of the word love, and then everybody gets an A and we leave. Right? If we're honest with each other, like we probably don't leave that room, right? We don't leave that room. And then the length of time we're in that room, our ideas about love are going to change too. So it's a really complex, complicated word. So you don't allow patients to use words that require, clarification. And the technique is really easy. It's a really, really easy technique. You just parrot the word. I'm really pissed off. Pissed off? Right? The patient will naturally expand upon that. So try this in your world. One of your friends will say, I'm so mad today. Mad? They're going to tell you why they're mad. They're going to expand on that, right? Or I'm really, really mad. Really mad? Right? And they will expand on that. Or I sometimes want to just punch the professor in the face, right? So there's all kinds of things in there that you can clarify, right? Sometimes, yeah, today I'm really mad at him. See what happened there? So they said sometimes, you don't know what that really means. And you said sometimes, and they said today. It's like, okay, so something happened today with the professor that's got you so upset that you want to punch him in the face, right? Or you could say, you know, I sometimes want to punch the professor in the face. Punch him in the face? Well, I don't want to punch him in the face, but I'm really pissed off. Pissed off? Well, I'm having a bad day, and the professor is, right? So now you've caused this, and think about the communication funnel. They started here saying a really vague statement, you pushed him down, and then you pushed him down, and now you're, you know, at the point where, you know, I had a really bad morning, and, you know, my dog bit me, and, you know, I'm just having a bad day, and the professor's an easy target, and that's who I want to take it out on. Right? So there, any words that require clarification is called the traffic sign, and the best way to clarify them is just repeat them. I'm trying not to cuss, right? Those of you that have classes with me know that I'm a cussing machine, so I'm trying to be appropriate. But, you know, somebody will say, I'm bleeping mad, right? You can say bleeping, right? That will cause them to clarify their position, or mad, right? You can just pick one of those, or you can just say bleeping mad, and they will expand on that, right? But this is a really important technique, but this is also one of those techniques too, where you don't want to catch every single traffic sign somebody says, right? Because a lot of people speak in really vague general terms. I'm so mad at everybody today, right? There's so many, you know, traffic signs in there, and you maybe let a patient get away with it for a while, but over time you get better. You teach patients, you know, that's an important thing. The patients that I work with will say, I'm so pissed off. Well, let me tell you what I mean by pissed off, because I prime them all the time. Like, I want to know what you actually mean, and what does that mean to you, because it's a different experience for me, right? And this gets into the word phenomenological space we'll cover in a second. But so now we have 3 skills: indirect lead, paraphrase, and traffic signs. And all of those skills are causing us to move down this funnel. Like, we're going from a very shallow form of communication to a very much more precise, right? And traffic signs are really good at that, because you clarify a word and you have to catch it, right? You have to get good at, because most of us, you know, somebody says, I'm really pissed off. You're like, yeah, you're really pissed off. But when you're clinical, when you're in this clinical role, what does that mean? You know, why are they really pissed off? And are they actually, what does pissed off mean? And if you just expand on that, then you start figuring out how your patient operates. Clear as mud, right? And now the next skill is the structure of the content, right? So the content is the thing that's being said, and the structure is the order that it's being said. You know, I'll try to be gentle with this, but Ecuadorians like to tell stories, right? And Ecuadorians like to tell stories with context, right? So you know, imagine you know this from whoever, you know, they want to tell their story. And so a patient will sit with you and say, so I'm having a really bad day, and, you know, my boyfriend is not being nice, but you know what, I need to tell you this other thing that happened too. And so last week my boyfriend did this other thing, right? And that's really like a circular kind of, you know, logic kind of a story, right? But you have to give it back to that, right? You give it back in that order. So it sounds like you're having a really difficult time with your boyfriend, and that causes you to reflect on the thing that happened last week. That's also very similar, right? And so now you've identified their structure, as opposed to, you know, I'm very circular in my structure in the way that I deliver lectures. I get sideways and tell stories. I'm going to try not to do that today, but I get off tangent pretty easily, but then come back. That's like a circular reasoning. Some people are really linear and organized. This is what happened. This is what I did. This is why I did it, right? Nobody loves me. Everybody hates me. I'm going to go eat worms, right? And so you give them back their structure. So nobody loves you. Everybody hates you. You're going to go eat worms. But now when you think about the structure, you get some idea of how the patient thinks, right? Lots of people think in really weird, chaotic ways, right? But we have to start putting, you know, clinical structure to that. You know, are they tangential? So I'm having a really difficult day and everything is really hard. And did I tell you I got a new dog? Oh, my dog is so cool. But let me get back to the other thing that I'm talking about, right? That would be like circular, but also tangential, right? So you're talking about something and then jump to something else. And when you summarize that or paraphrase that, you would say, so you're having a really, really difficult time and things are really struggling for you, and you have a new dog as well, and that's interesting for you. And when you do this and you do this well, sometimes patients will say, did I say it like that? Well, I don't want to talk about my dog. I want to talk about this thing that's happening. So you help them identify the way that they think as well. Very important in the clinical world, like how somebody thinks. Because what we do as therapists, cognitive therapists or systems therapists or analysts, those kind of things, is we help with changing the narrative, right? Changing the story that you say to yourself. And you can only change the story that you say to yourself if you understand how you talk to yourself. And you usually understand how you talk to yourself when you have a professional that gives you back the information the way that you gave it to them. Because we don't do that in the natural world, right? If your friend is, oh, nobody loves me, everybody hates me, and I got a new dog, you'd be like, hey, shut up about the dog. We're talking about your relationship. And they're just gonna, or you're gonna be avoidant with them. Then you don't want to talk about the relationship. Oh, let me see pictures of your dog. And then you start showing pictures of their dog, and you've effectively avoided this emotional thing that you want to talk about. In the clinical world, we don't allow that. We understand it, we recognize it, but the structure and the way somebody speaks is really important, and it's important for you diagnostically, right? And also to understand that. I have a bunch of patients who come in and say things like, I need to tell you about the thing that happened this week. And as they're telling me the story, they go back 20 years to give me some context about why this thing is, why the families are fighting, right? The Ecuadorian, like, we're mad at each other. But they need to have that process. They need to have this really circular process. They need to fill in the blanks. And so I have to let that happen. But then I also summarize too, and like, hey, that's really interesting that you went back 20 years. I think we need to stay present. Right, but helping them identify that, right? Because that's a thing that people do, kind of fixated on something back here that's affecting you up here. Maybe you need to put a period and move on. And then the word on here. And if there's any words on the PowerPoint that you don't understand, please ask. I'm not trying to trick you. And like when it says PT, that means patient, right? If you see something that says DX, that means diagnosis. DDX means differential diagnosis. This is really like a clinical presentation. So I'm assuming that you know that, but if there's a word you don't know, tell me, because the point is not to confuse you.
Richard?
And then, yes.
I'm sorry, someone has a question. Carolina Enriquez, if you want to talk.
Okay, let me hear it.
Richard, I've been having a patient, and I don't know how to stop her from talking.
Yeah. That's yes. A problem, right?
Yes, because she's like very tangential and circular and very kind of disorganized when she has her own order, but when she talks, she gets really lost in the topics. And when I'm trying to organize her to make like her follow a sequence, she gets kind of offended.
Yeah, because you're doing a crazy neophyte thing. You're doing what a new clinician does. I'm assuming you're new. I'm assuming.
Yes, I am.
You're newish. Yeah, so you're trying to force the patient into your world, like get in her world, right? And so
not that much, because the last cita, she like extended a lot the time because she wasn't. I don't know. I don't want to say in shutting up. I don't know how to say that.
That works. We can, you're not saying it meanly. The patient won't shut their mouth, right? They won't let you talk.
Yes.
Right? Yeah, that happens. But here's how you get better at that. Now you know you have skills, right? And so the patient's saying a bunch of words and you say, hold on a minute, hold on a patient. I do this all the time. Patient, stop for a second. Let me make, this is called perception checking, but it's a different skill. But I say, hold on, patient. Let me make sure that I'm picking up everything that you're putting down, and then give it back. Right. And if she's speaking in a chaotic, random, tangential, circular, whatever way she is, give it back in that order so that the patient can hear it. So what I hear you saying is that nobody loves you, everybody hates you, you're happy you got a new dog, and da 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 da, say a bunch of things, and the patient can maybe be like, yeah, and then you say, those are like 4 things. Let's pick one of those things and focus. Right. And patients can do that. Once you have to say, sometimes with the hands, hold on a minute. Let me make sure that I hear you. But now what you can say to yourself is, I'm going to give back the structure to the patient, right? They just gave me this long-winded explanation. I want to give it back, right? And then the patient, even if they're like, yeah, right, but then they're going to focus on something, and then you can go down that rabbit hole. You can focus where they've decided from the information you've given them. But another important concept is you have to, shut patients up. right? You have to tell a patient, hold on a minute, you've just said a whole bunch of stuff to me and I need to make sure that I got it. And then in my mind, I'm thinking, and we got to pick one or two of those areas and focus, because I can't focus on 6 things, right? Like I'm really good at focusing on a couple of things and then tracking all of the data back here, but we have to have a focus. And I think when you get good at the skills, it's easier. Like I work with a lot of clinicians in supervision on that, where I can say, pump the brakes and go do a bunch of structure stuff with the patient. Let's figure out what's happening. Does that make sense?
Yes.
So, and that's, patients tend to like, some of them really talk because they don't really understand what therapy is, right? And when you're like, I'm teaching like active, listening skills here, you have to sometimes say, whoa, and think about it. If a patient talks for 5 minutes, right, how the hell are you going to give all of that information back? Like you're not, right? And especially if it's a patient who's chaotic and circular and tangential, they've probably touched on 4 different topics. So you have to get good at saying, hold on. I'm tracking 3 things right now, and this is as much as I can track. So what you're saying is done. And when you get good, the patient will say, yeah. I say, well, let's pick one of those. Let's go down, the mother rabbit hole. Let's talk about the father, or let's talk about Fluffy, whatever the thing is. And it'll teach a patient to like pump the brakes as well, because you won't just let them unwind the whole time. Okay, good question.
Thank you, Richard. We have another question. You want to continue with your presentation, or you want to answer the question? What do you prefer?
Question.
Okay, so Pablo and Dara, you have the raising, so you have the
Thanks.
word.
Richard, I have a question. What happens with these patients that are like not too much young, but I mean, for example, 17, 18 years old, that sometimes come to the therapy, maybe forced by their moms, and they don't want to talk. How can I abort them? How can I initiate a conversation with them?
Super easy, man. Super easy. Like think about it. How do you join the adolescent in their misery? How can you join that? Right? That's the process. So the scenario is the adolescent is brought by the mother and they don't want to be here, right? And so you bring them into the back, and I do stuff like, wow, your mom seems pretty intense, dude. Like, what's up? Right? So you join them. They're like, yeah, my mom is so mean. Like, I can't even believe I'm here. And then, you just get into the conversation. Well, I say stuff, well, you know what? I don't want you here if you don't want to be here, but your mom wants you here. And since we're here, like, what do you want? Let's work on something. Let me help you get something sorted out. Like maybe a better relationship with your mom, or like what's happening in your life. Like share with me something, and let's do something. Right. So you have to like demystify the whole therapy process. But with adolescents, I join all the time. I join. Like you see the parents come in and they're all, doctor, we need to talk to you. I'm like, hold on, let me start with, little Jose first. And I bring back Jose and I'm like, dude, like what's up with your family? They seem pretty intense right now. And then that'll break the borders down a little bit and they'll talk to you. Adolescents are difficult for sure, right? Because they don't want to talk and they don't maybe want to be insightful, even if they are insightful, and they don't want to deal with it. But if you can get, I join in the misery all the time, and it's not like bad mouthing their parents, but it's like, holy crap, your mom was giving me the eyes today. Like, what's going on with that? She's really pissed off. Yeah. Or I noticed that, your mom seemed to be giving you the cold shoulder, man. What's going on? Right. And so you like join them, like you identify, this is like formalizing nonverbals, but you join them in their misery. Right. And I join them in there. Like, I know you don't want to be here. Like, this is difficult and this is tough, and let's figure out a way to make this less difficult and less tough. Let's talk about something that you want to talk about, right? And then once you get them talking, then you can get into the dynamics of whatever's happening. It's always, the separation individuation thing that's happening with the adolescents, trying to be their own person in a system that doesn't want them to be their own person, but demands that they be their own person, right? It's a very confusing, adolescence is very confusing, right? I mean, you know more than me because you were there sooner than me. I'm like 52. It's been a long time, but I do remember that it's very confusing. And I work with a lot of adolescents, and getting back to the technique is just joining. I join a lot. And when I work with adolescents too, many times, because, the rule of confidentiality in Ecuador is the age of majority, right? So parents have all of the rights to know everything until they're 18, but you live with your parents until you're like 24. So parents want to know anything anyway. But if somebody brings in like a 16 or a 17-year-old, I start with the kid, right? I start with boundaries right there. Hey, come on back. You know, I say, hey, mom, dad, okay, we talked on the phone, and this is little Jose. Okay, Jose, let's go. Let's start. We'll leave your parents out. And so I start with creating this bond with the kid and helping them with boundaries with the family. And then I let the family visit the sessions and give me any data they want to give me. And then I kick them out and I work with Jose, and I do things like, you know, hey, you know, your family's going to come back, and what are they going to say to me, man? What's going on? And so you can start that conversation. And that I find is a great way to start with adolescents, because if they think they can trust you a little bit, right, and then you can demonstrate that they can trust you, they'll open up. But it's hard. Adolescents, or therapy in general, is much harder than you probably think it is. Okay, did that answer your question?
Yes, Richard. Thank you very
Okay.
much.
Yeah. Was there another one?
Thank
Or
you,
can I?
Richard. We have another question.
All right, let's hear it.
Okay, so Emma Garcia, please say us your question.
Hi everyone. Hi Richard.
Emma,
So
long time no hear.
yeah, I email you something important. So
Yeah, I saw it, but you're on my schedule, right? So we'll talk about it. But yeah, go ahead. What's your
yeah.
question?
Okay. So on that note, how can I work?
Yeah.
Do I join them in their misery as well, or?
Yeah. You really think I look young and stupid, don't you? Yeah.
Yeah.
Well, you know, so when I was at CMA, you know, and we developed like the internship program there, that's a thing, right? Like older people working with younger clinicians is an issue. The way we addressed it at CME, which was a beautiful sneak attack that nobody saw coming, is that, you know, I was allowed to give the interns white coats, right? And so the white coat, you know, gives you some credibility. So when you walk out of the room and you're 24, but you got a white coat on, people are already deferring, right? Because you obviously know what the hell you're doing. But without like that, I mean, that's a challenge that you're going to have, that enjoy it, that you have it, right? Because eventually you're going to be like me, and everybody you treat is going to be younger than you, right? And there's a lot of research that indicates, you know, older therapist with some kind of connection with the patient, that's the thing that works best. But if you're young, you know, you don't have that. So I would say it would be the same thing. Acknowledge that, you know, acknowledge, hey, it seems like you might be struggling with with my perceived lack of experience, right? And see what they say. Because you probably have way more experience than they think you do, right? Because you have 5 years of, like here in Ecuador, you have 5 years of training and 5 years of advanced training in psychology, and you've been supervised while you're practicing, and you spent massive hours and mental horsepower thinking about this thing and doing this thing, and you've worked with a lot of patients. And so sometimes they just need to hear that, hey, this isn't my first rodeo. You know, I might look like a baby, but I've been doing this for a while. And I think your time starts when you started your psychological training, right? You're treating somebody that's, you know, twice as old as you, but they have a business degree. What do they know about psychology, right? And you can say, look, I've been studying psychology for 5 years. I've seen lots of patients over the last few years. I have some experience. So it's like, you know, acknowledging, and I guess Emma too would be like being transparent. I think that's always important. And if you have a sense that a patient is like not trusting you, like I always address that. It seems that, you know, we're not really connecting. That my experience is that you're struggling with me, and I wonder if it has to do with our age difference. And put it on the table, and then talk about it. And many times that'll clear up, right? Because you're willing to address this difficult thing, right? Or you might have a patient who's just difficult, right? They're not going to talk to you or me, right? We're both going to have to work. So that you have to separate that as well. Okay, may I move on?
Okay, right now we don't have more questions, so please continue with your excellent presentation.
Thank you. Excellent presentation. I don't know about that. Okay, so the next thing is the furthering response, right? So we have indirect leads, we have paraphrasing, we have traffic signs, and then it's like, where do you want the conversation to go, right? Because sometimes you want conversations to go a specific area or a specific place, right? But in the furthering response model, there's two different ways we can do it. There's a wider furthering response or a deeper furthering response. So an example is, you know, for a wider one, you might, you know, if you have a patient, say the adolescent that, I don't know the student's name, but the adolescent case, you know, you might say, you know, talk to me about your family, right? And that would be like a breadth, a wide response, right? Share with me some information about your family, right? So you're expanding. Or maybe you want to know specifically about the dad. You could say, talk to me about your relationship with your father. That would be like a deeper, right? So family is general. And then if you want to know a specific in the family, get deeper, you know, talk to me about why you're here today, right? And then maybe talk to me about why your mom was so upset with you in the waiting room, right? So you're getting into the focus, the specifics, but understand, like these skills layer, right? And that slide comes up in a couple of seconds, but these skills layer, right? So you don't start with a furthering response. You don't start with traffic signs. If you're working with Judy as my patient and she sits down and she says, I'm like really pissed off. I'm not going to say like really pissed off, right? Because that's going to be, but you can say, it sounds like you're like really pissed off, right? So you start with the paraphrase and she's going to say, yeah, you understand me, doctor. Nobody understands me. And I promise you, especially any of you that are already practicing, if you slow down and just start using these skills and get good at paraphrasing, get good at catching, like every fifth traffic sign or patterns of traffic signs, you're going to hear things from patients like, you really understand me better than anybody else. And then if you're honest with yourself, you're going to say, well, I'm just hitting some skills here, right? And and then you can be like, but I'm glad that you're having this connection with me, but you can see the relevance of the skills, right? And especially like the guy that was talking about adolescents are difficult, right? And you want to try to get them to work on some insight oriented stuff, but they won't talk to you, right? But you start hitting some skills, you'll find this kid will start opening up to you, right? And you start every session with that, like, talk to me about your week, share with me what's happening. It sounds like you're having a difficult time and you're really pissed off today, and you just get better at catching those things, and the kids any patient will open up more to you. But furthering response, just quickly and easily, it's, you have a wide understanding or a deeper understanding, and you get to pick as the clinician. If you're working with a patient and they have a lot of family issues, and for me, like if it's really, mother-father relationship, I'm going to start with, talk to me about your family. Let's talk about how those dynamics are. And then specifically, talk to me about your father, right? And listen for what's happening. And then when you say that, talk to me about your father, then they're going to say some shit, and then you're going to paraphrase that. My dad's really mean to me and he makes me eat worms every day. So your dad's really mean to you and he makes you eat worms, because that's an important thing too. You have to, if you understand the communication funnel, right? You understand that it's moving up and down, and you're maybe focused really deep on something with the patient, and then they shift on you. Like, my mom is really making me mad and I'm having a really, really hard time, and I got an F on my exam, right? Maybe that's an indication they don't want to go to mom anymore, right? But then you can paraphrase that. So it sounds like you're really struggling with your mom, and there's some things we should discuss there, but the F is really bothering you as well. Yeah, but let's stay with my mom. Like, a patient will indicate that. But if they say, yeah, I want to talk about the F, then you're back up on the communication funnel. So now you have to do some paraphrasing to get them back down, right? So that, for me, that process is very helpful. Like, I visualize this when I'm with patients. I understand like where they are in the funnel and what I can do, right? All right, and then now we're getting to more advanced skills, right? Because there's always a message that's being sent, right? Messages are important, right? So if a patient says, nobody loves me, everybody hates me, I'm gonna go eat worms, right? There's nobody loves me, everybody hates me, I'm gonna go eat worms. But what's the undercurrent of that? Like, what are they really saying, right? And think of it like this: if a patient comes in and says, nobody loves me, everybody hates me, I'm gonna go eat worms, and you say, you really feel defeated in life, that's too much, too fast. I mean, like, what? Right? But if they come in and say, nobody loves me, everybody hates me, I'm gonna go eat worms, and you say that, and then you're having this conversation, and you're catching some traffic signs, and then they say the same thing again, my relationships is really hard, and my mom's really bothering me. The message behind that is something. You have to learn to pick that up. What is the message? You're really struggling with the relationship with your mom, and it really worries you. Yeah, you really get me, right? But now if you think about what you're doing, you're shifting gears, and you're having a different technique, right? You're paraphrasing the message that the patient is sending to you. You're down in the communication funnel. And if you mess it up, they're going to jam you right back up. Or if they're nice and pleasant, they're going to say, no, it's not that. I have a patient right now that every really good paraphrase I do, he's like, I don't think it's that, doc. I think it's something else. And I know that I'm right, because it's easy to see, right? Because when you're a clinician, you get, like, he's got this idea of who he is, and anything that kind of assaults that idea, he can't really process. And so I do some paraphrase of the message, like, you really feel like people aren't treating you fairly. And that's exactly what he says. And he's like, I don't think it's that. I just think people don't treat me fairly, right? So he like shifts, but it's like so I've paraphrased the message, but there's the disconnect. And this is an important thing as being a clinician, is you're not perfect in these skills. And when you get better at the skills and then a patient gives you some resistance, you need to think, okay, that's diagnostic, right? Am I seeing how the patient operates in the world now? Because now we have this transference, countertransferential thing going on. Like, I'm seeing how other people have experiences with the patient, or are they just being difficult with me, or what's happening with that? And that's the importance of understanding the skills. It's like you have to, skill, and then the artistic part comes later. But you have to grind on the skills, get good at the skills. And think of this, always remember this, all of you. Like the only way that you become an expert in anything is you make all of the possible mistakes in that arena to become an expert. Right? You just don't show up and work really hard and like, oh, you're an expert. I'm a really good clinician. I don't even know if I'm really good. I'm a decent clinician because I've made a ton of mistakes and I've learned how to, recover from the mistakes. It's true for any field, right? But it's more true for us in the clinical world. Like you become an expert, you're gonna have to sit with a bunch of patients and hurt them and do weird stuff and make mistakes and recover from that and then figure out, how the techniques work and be able to recover from, patients saying, no, that's not what I said. And the first few times you hear that, you're gonna be like, oh. You're gonna, it's gonna hurt you. I promise you. Like it's gonna get your ego. You're gonna think, I can't do this. But maybe it's really important and it's really diagnostic, and that's where supervision comes in. You get a good supervisor who you can put everything on the table and they can help direct the skills, right? But back to paraphrase of message, and when you're doing the message, you're down deep in the communication funnel, but you have to expect that you're going to potentially get it wrong many times. It sounds like you're really upset about your relationship with your mom. Like, no, it's not what I'm saying at all. Like my mom's completely out of control, and that's not what I'm saying. You have to like pump the brakes, right? And say, okay, so help me understand what you're saying, right? Saying those kind of things matter. And here's where we get into the layers. And this is, scaffolding means you build up, right? And these skills build right on top of each other, right? And they build in session. Like you're gonna up and down the communication funnel all through the session. You're working with a patient and you've done a good paraphrase and you've caught some traffic signs and you did a good furthering response and you're really focusing on the relationship with the dad, right? And then they shift into something else. You just don't stay at the bottom down here, right? You have to work your way back down again, but it's usually much quicker, right? The paraphrase can be much quicker, right? Okay, so now you want to focus on your mom and you're struggling with the relationship there, and then you jump right back down. But if you don't have that idea, I've seen this a lot of clinicians, then you get stuck, right? And getting stuck clinically is messy, right? It's messy, and I think I have that later. But
excuse me, Richard, we have another question.
Sweet, let's hear it.
Okay, so Priscila Navarrete, please tell us your question.
Okay. Okay. So my issue is like, there's this person who's like really, she's really religious. Okay. And so, she believes that everything, like she has no control over her fate and like her decisions. So how, like, then why are you in therapy? I don't want to be like, it's like, I don't know how else to paraphrase that.
Well, but so this, we get into this whole thing when I do this class, like worldviews. Worldviews matter. Your worldviews matter, right? You have a clash in worldviews here because you obviously don't believe in the little box that she lives in. But you have to join patients. Like I use Jesus against patients all the time. That whole, what would Jesus do? I love that. Like you're very religious and you're really into that. And what would your Savior say about that? What's something that they would say? So use it with them. But the other thing like I want to say on that is it makes me, I go to physical therapy. I get a bunch of shoulder issues and the physical therapist is really cool. And she was talking to me about, she said, I have a lot of people that come to me that don't need anything. They don't have any like I'm damaged. They don't have any damage. She says, I think they just want me to touch them. They just want like this connection. And I was like, you're probably right. Like it's a big deal. And she's like, but I feel bad for taking their money because they're coming. But like, you can't really make that, that's, I can't help her with that call. But she was, they need that. And so sometimes patients need this human connection. I teach a bunch of theory classes and at the end of all of my theory classes, I'll say something like, everything that I just said to you probably doesn't matter. Probably the thing that's working the best for this whole process is the relationship. You being pleasant and kind and tolerating the patient's madness is probably curative on some level. And so I keep that mantra going. So this patient who's coming to you feels stuck and can't really move because of her religious thing, she's gaining from this human interaction she's having with you. But clinically, I would say something like, it seems that you're in a really challenging position because, you have this idea that everything is thought out for you, yet you want to make some decisions, right? Like help clarify this, You believe that fate explains everything, but you're almost, paralyzed within that. You're not making any of your own choices. You'll help with clarifying this position that she has.
Right.
I find that helps with religious people a lot. Like, and a lot of them are that way. They have this kind of paralytic position, like they're paralyzed. They're believing in this greater thing that's happening, and then they don't make any of their own movements. Right. And I think even the Bible says, Jesus says stuff like, do stuff, I don't know exactly what he says, but something along those lines. It's better to do some things and make some moves for yourself. But yeah, those are challenging cases. And I think that for you, the work is like worldview adjustment, right? And maybe, I don't know, no judgments here, but maybe you're not the best therapist for that if your worldview is diametrically opposed. I have my worldviews, and I know the kind of people that I'm really good with working with better than others. And if somebody comes to me and they're not going to fit with my therapeutic framework, I refer them out. I refer out about 2/3 of the people that actually come to me. I have a pretty good idea of the things that I'm relatively good at. And if you come to me and that's one of them, if they're really, really religious and they really want like this spiritual, like I'm not that guy. So, I try to assess for that in the assessment, and I'll give them somebody who can address that better, right? Because even think like your case, if you struggle with that because your worldview is different, but somebody has a similar worldview might, be able to move them along a little easier. Or, the opposite is maybe they need you, and you just have to figure out how to get them. Okay, was that a good enough answer? All right, so let's get into it. Somebody asked me, like, how do you help people with feelings? So now think about it. We're going to do reflection of feeling. This is the thing that all of you practicing clinicians are doing way too much, way too fast, way too soon. Like, stop it, right? Build the skills. Do the paraphrase, catch the traffic signs, do the furthering responses, listen, paraphrase. Because the other thing, like if you do a furthering response, talk to me about your family, they're going to say some things and you paraphrase that, right? And you go back down the communication funnel. You don't hear about the family and say, well, it sounds like you're really sad, which is what a lot of you do. I did it too in the beginning, right? Because this is, as clinicians, we think this is where we're supposed to work. Like we're all about the feelings, and feelings are really down in the communication funnel, right? But it really helps with, lots of people mislabel their affect. Lots of people cry when they're angry and laugh when they're sad, and they have this lots of, internal confusion that's happening, and you see that in session. And so sometimes you have to help label that, right? And it seems like you're really, really sad about this thing. I'm not sad, I'm pissed off. Oh, and you're like, okay. So it seems that you're really pissed off, but you might know from the history of the patient that they're actually sad, but they're acting out from an anger position. But is it actual anger or is it something else? Right. And that's part of what the therapy is like to figure that out, help patients, silo that. I think I should show you guys this quick picture because I was just doing an intro psych class and I have this great PowerPoint picture that explains emotions really well. Right, because everybody thinks, you see the new screen? Like everybody thinks that there's so many emotions. There's really not, right? As a clinician, we need to break things down, but there's 5 primary: love, joy, anger, sadness, fear, right? Those are the primary emotions, right? Those are our primary emotions that we can all basically agree upon. If I showed you faces of, if I showed you all of face of disgust, like 90% of us would agree with that, or we'd identify that without even being primed. I'm going to show you pictures and you would be able to identify that. But then from that, there's like 15 other secondary emotions, right? It's not, I had a friend who just wrote a paper on love, and he wrote like, I think it was like 31 different kinds of love. And I was like, Jesus, he's like so complicated, right? And he explained it all really well, and it makes all really good sense, but it's really intellectual, right? And it's, for me, it's, I can't treat 31 different flavors of love, but I can really look at love as having, fondness and infatuation, and make sense of it, right? So emotions are something that, we have to spend a lot of time trying to understand. But for me, it's understanding that you don't understand them. The way that I interpret love is my phenomenological space of love, my internal position, and yours is different. And love is a traffic sign, right? And if you understand that, then you'll go down that rabbit hole better. What do you mean by love, patient, or love? Right. But the other important thing I think, like that, what this diagram shows too, is we're much better programmed to see the negative than we are to see the positive, right? There's twice as many negative emotions as positive emotions, right? There's 10 secondary negative and there's 5 secondary positive, right? That matters, right? So it's like, that's a an important thing about feelings and emotions. But then back to this slide, I'll tell you there's 3 important rules with emotions. And if you understand them, you'll be better at being a clinician. Because part of the key to being a good clinician is to be curious, right? And to have humility, right? You have to understand that you're going to get beat up in session because the patient wants to beat you up, or because you're an idiot, or because that's just the way it goes. And there's a lot of back and forth that happens, right? If you have like a 4-point GPA and you're driven to be the best at the thing that you do, you're probably not going to be a great therapist, right? Because therapy is messy and ugly and sloppy. There's all kinds of weird things that happen. Patients get mad at you and say hurtful things to you. And then if you've internalized that in a bad way as a therapist, then maybe you act out with your patient, in meaning become punitive, more homework, more difficult, pushing more than you probably should. So therapy is this really weird thing, but you have to stay curious, right? That's how you stay connected, in my opinion, with patients. But feelings are, I'm going to move past this. I'm going to talk about the 3 characteristics of feelings, because I think it's very important. And how are we doing on time? Shit, we're out of time, right? Should I keep going, or what should I do, Judy? Oh, but should I have appointments as well?
If you have time, we can keep going.
Okay, let me go through this, and then we'll have to stop.
Yes, and also we have one more question, so the question can be from the final if you want.
Okay, hold on. Yeah, let me talk about it. I just want to look at my schedule and see if I have time or not. I have an 11 o'clock, is it? Yeah, it's 11, so yeah, so I got like 10 more minutes. So, but emotions are very, very complex and really difficult to understand. But if you understand them from this position that I'm going to explain you now, and you stay curious about that, you'll be a better clinician, right? And understanding that when somebody's having an emotion, even if it's not, we're not thinking about labeling it or any of that stuff, but they're having this reaction, this emotional reaction. It's present tense, right? See somebody crying or somebody being angry, like, I'm mad because of the way they treated me. They're mad right now, right? They're having this emotion right now. It's present right now. I can easily start crying about my grandpa who died when I was 18. When I start talking about that story, like, I have that affective discharge right now, right? So that's how emotions work. They're very present, right? When you start bringing up these emotions, it's present, right? So honor that with the patient. And then if you honor that and understand that emotions really need to be expressed, right? Think of the time that you've tried to hold back tears, right? And you held them and did the girls, and then you get somewhere and then you cry, right? Or holding it back. Like, it's a really, really challenging, difficult thing, even in therapy, right? Many times you have to do what's called pulling for affect. Say something to the patient, like, I can see that you're really affected by this, or I can, it's okay, cry. Lots of early clinicians are good at stopping patients from crying, right? You shift the topic. You move away from the affective discharge because it makes you uncomfortable. But if you understand that emotions need that, they almost demand that. They demand to be expressed, right? And if there's any inward blocking or things that happening, that's where we get into trouble. You get repression and you get the stuffing of the feelings, and like anger is like drinking poison and hoping other people get sick. People that run around, they're angry all the time, they're just destroying themselves, right? So you have to understand that the emotions really demand some kind of expression. And the last piece is they really need to be understood, right? They really, like us as human beings, we have this need or this desire to be understood. It's a lot of times why people come to therapy, because they're not understood other places, and they come to people like us. And if you're really good at skills, they're going to say, you really understand me. And if you're really good at understanding yourself, you can say, I just hit a bunch of skills. I don't know anything about you yet until I work with people long term. And when you know people over many years, you know them, but you don't know them, right? You don't know the phenomenological space is very different. And patients lie to you all the time, right? And they lie because they want to, or they lie because they don't know it's relevant information, right? It's a thing that happens. But when you see some affective discharge, a clinical way of saying emotions, right? You have to understand, hey, this thing needs to be expressed, and there needs to be some understanding, right? And so then you reflect some feelings on that. Like, Judy, I can really see that there's something happening with you today. I can see something's going on. Talk to me about what's happening, right? Without labeling the affect, right? That's the way I do it. Because when you ask somebody how they're feeling, how do you feel? They're not going to feel for you. They're going to think about their feeling and tell you cognitively how they feel. And it's a whole separate discussion. But when they're having this emotion, when you're the clinician, don't be scared of that. Encourage that. Like, I can see there's a lot happening with you. And then you have to take a stab at it. It really seems like you're really, really angry about this thing today. I'm not angry, I'm sad. And they're like, you're like, okay, so your version of sadness is something that I don't really understand, but let's get into what it means for you, right? Because emotions are super complex. But I always, you keep the 5 plus the 15, right? Don't get into all this 27 layers of love. That's probably true, but in the clinical world, it's really hard to imagine if there's 27 or 31 kinds of love, and then for every one of those things, he can come up with 30. So what's 30 times 15? That's a big ass number, right? There's a lot of emotions to have to sort out. For me, it's easy to keep it simple, right? And trying to keep things, moving in therapy. Okay, so let's ask questions, and then I'm, sorry I didn't plan well enough to get through all of it, but we have a lot more to go.
Thank you, Richard. We have 2 questions. The first one is by Jocelyn Sanchez. She asks us, what happens when a patient talks about the same topic from almost 5 sessions? She repeats the same story and ends with, but there's nothing that I can do.
Welcome to therapy. There you go. Welcome to being a therapist. It's really hard and complicated. I mean, I need much more details on that, but so a patient is looping out, perseverating on one topic. So you help them identify that they're looping out and perseverating on one topic. You use some furthering responses to maybe get them away from that topic. Sometimes clinically, you have to make some decisions like, hey, I say sometimes to my patients, hey, I don't want to talk about the relationship today. I know it's a problem. I know it bothers you. I know you want to talk about it today, but I really want to go down a different avenue because I think it might be beneficial, right? And so you give some direction, and if they can do it, great. If they can't, then you hang with them, and then you try different techniques. Like I try that. I have many patients that loop out, perseverate on the same thing, and they'll start with. I have one that starts with, like, how you doing? I'm ready to jump off the cliff. I'm like, okay, cool, but you didn't do it this week, so let's talk about something else. Right, we'll come back to that. I'll give you the time to talk about jumping off the cliff at the end, but let's focus on something else. You have to but that's the artistic part of being a clinician. When you're new, I think it just makes sense to listen and to reflect and get good supervision. Like you need to have a supervisor who can help you in the minutia of the case. Like that's really important as a developing clinician, is having somebody who's frankly just better at you at doing that because they've been doing it longer, right? They think, like worldviews matter. Like if you're a hardcore Catholic Christian and then you come to somebody like me for supervision, it might not be a good fit because my worldview is different. So those things matter in supervision, but those kind of things that you just talked about, Jocelyn, need to be worked out in supervision because it's helping a patient identify their patterns and then containing, right? A lot of times we have to contain a patient. Like, I got it. Nobody loves you, everybody hates you, you're going to go eat worms. And this is the thing that's been consistent for 5 weeks, but I haven't heard much about your family. So can we focus there a little bit today? Right, and learning how to be, directive, but also pleasant. Right? You can be really direct, but do it in a way that's not offensive, right? And most patients can tolerate that pretty well if you say it like in the way that I said it. But you also have to understand too, like it takes a long time to get good at this, right? I mean, I have so many words because I've been doing this 20 years. I've been doing this a long time, so I can just come up with the language because I've been through the ringer a bunch of times. And that's what you need as well as clinicians. You need to get beat up a whole bunch of times. The next time you have a patient that does that, you'll have a better, framework to deal with it. But supervision is probably the answer for that kind of dilemma. Okay, was there another question? And then I got to run.
Yes, the last one question that we have by Ana Belén Chavez. The question is, what can you do if a session is ending but your patient is in the middle of the breakdown or a very strong emotional reaction? How can you give them appropriate closure?
Yeah, so you did a bad job of session management, you the clinician, right? But there's a couple things on that. I always laugh at this. The most important thing a patient's going to say to you is usually with their hand on the doorknob. Oh, hey, did I tell you I was getting a divorce, doc? And then they're going to leave and like, ah, and you have to use it. Or, hey, did I tell you I tried to kill myself last week as they're leaving? Or I had a patient literally say this to me, hand on the door. Did I tell you that I poisoned my dog last week? And I had to say, oh, sit down. Like, what? And I had to, so you had to expand the session. You have to kind of go with the flow. But generally speaking, like the way that you need to understand a session is that if a patient is having a lot of emotional stuff, they're discombobulated, decompensating is the clinical word. They're losing their shit, the non-clinical word, right? You allow that to happen and you reframe and you reflect, but you need to understand too, you got to put them back together because they got to go face the world. right? After you've tore them down into little pieces in this session, or they had this whatever meltdown, at some point you have to say, okay, stop, patient, breathe, right? We only have like 10 minutes left. Let's get yourself together, and if they can't, right, then they're in some strange crisis, and you need to, supervision is probably what helps for that. And you need to, and if they're completely not able to leave, then you have to give them some more time. But you also, for me, be clear, like, hey, I don't want to be rude. I'm not, there's other people that are coming, and you're having a rough time, and let's breathe a little bit. Let's get yourself together. You got to get yourself back to class, or you got to get yourself back to your life, or you got to, so, but I do that, I'm watching the clock a little bit. If they're really losing their shit at minute 30, I'm going to start pulling them together, because it might take, and you have to learn that about the patient. Because I have some patients that can pull it together really quick. I can say, we're close. Whew, okay, give me the mirror. And they start getting themselves together because they've been trained. And I have some that leave crying, right? And that's just their MO, right? And so you have to get comfortable with that as a clinician. Like, how does your patient operate? And then be able to know what is a legitimate crisis and what is, not a manufactured, but what is a crisis of the moment, and it's the style of the patient. But if they're, losing their shit consistently, at minute 30, 35, start summarizing the session. Hey, so it looks like, and you really need to get yourself together. We only have a few minutes left. Like, do you need a cup of water? Like, and then you indicate to them, like, hey, we're done. Like, pull yourself together. Because I don't like letting patients leave completely, decompensated, but sometimes they do. I had a patient like, well, it's been a while ago, like, called me all kinds of crazy names, and I was the worst clinician on the planet, and how dare I continue to think that she's the problem when everybody else is the problem, and left the room screaming and mad, and told my assistant what she thought of her, and left. And my assistant came back, oh shit, what do we do? I said, just keep her appointment for next week. We'll see what happens. She came back the next week, and she's like apologetic and cool. So it's like, it's hard to know that. But back to your question, you have to learn to gauge that. And I think it's probably bad session management on your part, because you're a new clinician, and if you have a patient who unravels, right, start putting them together at minute 30, 35, whatever they need, so that you can, because I think on some level we're obligated to put them back out into the world, at least in a functional state, if we can. Because therapy's hard work. Sometimes you rip people apart, and then you're like, bye, next. But you have to have this process of pull yourself together. For me, some of it's, do you need water? Like, I have a mirror in there because, the women in the makeup, and they can organize themselves like that. That stuff really matters. Those little things really matter. Okay, I have to go, everybody. So it was a fun talk. I hope you learned something.
Thank you so much, Richard, for your time. It's been a pleasure. Thank you, everyone that were able to connect today. And we hope to see you in another speech, Richard, because they didn't want you to go. But thank you so much for your time.
Yeah, I mean, I can finish this if you want, but we have to figure out a schedule.
Yes, we will talk to you about this.
Okay. All right, everybody, take care.
Thank you so much, Richard. Thank you, everyone.
Okay.
Bye.
Bye.
Bye, Richard. Thank you very much.
Bye.